So now we're going to talk about our second class of protein synthesis inhibitors. They also act at the 30S ribosome, and these are the aminoglycosides. Again, make sure that you take a look at the animation of where the aminoglycosides are acting. So we've got gentamicin, tobramycin, amikacin, and neomycin. The mechanism that you need to know are that they're irreversibly binding to the 30S ribosome and that they're inhibiting protein synthesis. There are a couple of ways that they're doing this that have been talked about in the literature, but one of the major ways is that they're binding in a way that blocks the proofreading of the codons, so that it's much more likely that the wrong amino acid is going to be put into place in the growing peptide chain. So if you have the wrong amino acids in there, then that protein is not going to fold properly. And if it's a structural protein, it's not going to bind into what it should. And if it's an enzyme, it's not going to have proper catalytic activity if the sites are not shaped properly. So aminoglycosides have some really interesting toxicities that are going to limit the route of administration. So you guys know that when you give something IV or IM or PO, you're going to have systemic concentrations. And when an agent is systemic, it's going to be able to affect any organ in your body. And so you're going to have potentially a lot more toxicities than you would if you were taking a drug topically. Yes, topical agents can be absorbed, and we rely on that sometimes, like a birth control patch. We are definitely hoping that's absorbed. But when we use a lot of topical agents, what we are looking for is for it to act at high concentrations right where we put it and have little absorption so we don't get any systemic activity. The problem with aminoglycosides is that they are toxic in the ear and they're toxic in the kidney. So adults who take aminoglycosides can have some hearing loss that's irreversible, and they can have kidney damage that luckily is reversible. One of the more problematic factors of the ototoxicity is that if a woman takes it while pregnant, there's a possibility that the infant will have permanent deafness. And so these are drugs that, because of all of these toxicities, are obviously avoided in pregnant women, but are also only really used systemically if necessary. What you're going to see more likely are these topical forms, and those are available OTC as ointments like Neosporin, and you're going to also see prescription ophthalmic and otic routes to deal with eye and ear infections. So why is it okay to take this dangerous drug topically? Because it's not going to have systemic actions, and so it won't have those major toxicities. So our next class is the macrolides. You've all heard of the major macrolide, azithromycin, and that's the drug in the Z-Pack. We also have clarithromycin and a couple other ones that you'll probably recognize the names of, but you're not needing to memorize right now, including one of the first ones, erythromycin. So here we've moved to those antibiotics that are binding to the 50S subunit. And the macrolides are going to bind to a specific site called the peptidyltransferase center. The reason that I want you to actually know that binding site for this drug class is it's overlapping the same site that the next antibiotic group binds to. So lincosamides and macrolides are basically binding here, both binding at the peptidyltransferase center. And you can't get two drugs in to the same place at the same time. So you're going to have interactions in which a macrolide and a lincosamide are going to block each other. Good gram-positive activity, some gram-negative activity. An important factor about azithromycin that we're going to see is that it has a very long duration of action. And that long duration of action comes from a couple of different things. It has a strong post-antibiotic effect, and that's when an antibiotic continues to have effective action even once the antibiotic itself is gone from the system and the cell. The second reason it has a very long duration of action is that it has biliary elimination. It's excreted in the bile, it goes into the GI tract, and then it can be taken right back up through the GI tract, creating that little cycle of enterohepatic circulation, which can extend the duration of the drug in the body. Some effects of the entire class of macrolides are that they can cause QT prolongation, and we saw some other drugs that did that. In general, the macrolide class can cause inhibition of CYP3A4. And that's a pretty important point when it comes to drug interactions. One of the reasons azithromycin can be more widely used than some of the other macrolides is that it's an exception to that. It does not inhibit the CYP3A4s. However, it does have some issues at the liver and at the gallbladder, and it can cause hepatotoxicity, and it can cause jaundice. So let's look at that Z-Pak. Of the macrolides, azithromycin is the first choice, and that Z-Pak is something you're going to see every day. So why is that? Why are we picking azithromycin to use as this very common agent? The first thing is that it has extensive tissue penetration. So what that means is, say you have an infection in your kidney or you have an infection in deep muscle, you need that antibiotic to actually get into that organ where the infection is. Normally with antibiotics, we're just relying on it being in the circulation, it being passively diffused into the tissues. Azithromycin is actually distributed into inflamed tissues selectively. It concentrates inside phagocytes, which are then going to directly target inflamed tissues, and those inflamed tissues are usually the ones that have the infection. So that extensive tissue penetration is one of the big points in favor of azithromycin. The second point in favor is that long duration of action. And that duration of action, the T1/2 is actually 4 days. And that's why they come here and they say Zithromax keeps on working. So you take it for 5 days and it keeps working for 10 days. That's because of that post-antibiotic effect plus that long half-life. The other reason this is so popular is it doesn't have that CYP3A4 inhibition, and it actually has better gram-negative coverage than the other macrolides do. So it's able to cover a larger number of common infections. The next protein synthesis inhibitor class also acts at the 50S subunit of the ribosomes, and these are the lincosamides. The only drug example we're going to give you for this is clindamycin, which is one of your top 200s. I mentioned these when we talked about macrolides. These bind reversibly, but they bind to the 50S subunit at the same site that macrolides bind. So one of them binds, the other one can't get in. These guys are going to have mainly gram-positive selectivity, and the main important thing you want to know about these in terms of the special information is that it has a lot of gut activity. So all antibiotics can give you diarrhea, upset stomach, and the possibility of superinfection. If you're taking an antibiotic orally and you're killing off good bacteria, that leaves possibility for overgrowth of fungi and bad bacteria, and can give you superinfection. Clindamycin, when taken orally, is much more likely to cause an opportunistic C. difficile infection. And that can be very severe, and it can sometimes be fatal. So while that is the case of possibility of superinfection for any antibiotic, this is a special boxed warning that that's a significant problem here. One of the last protein synthesis inhibitors, oxazolidinones, say it after me, oxazolidinones, includes linezolid, which I can remember is part of this class because it's a linezolid. So linezolid is an oxazolidinone. We also have tadazolid, which is a prodrug of linezolid. These guys have a unique site on the ribosome, on the 50S subunit, that no other antibiotic class that we have binds to. So we're not going to overlap the binding site of any other antibiotic. These guys have good gram-positive activity, but the most important thing is that they are pretty good for MRSA. You're going to see MRSA written here 3 times on this slide, so that should tell you something. Because it still works for MRSA, they don't want to give it for other infections where the bacteria could now create mutations for resistance to this drug class. So it's generally being held aside only for MRSA infections. One of the interesting points about linezolid is that you can't take it within 2 weeks of an MAOI. That was a monoamine oxidase inhibitor. And you're told to avoid consuming large amounts of tyramine-containing foods. If you remember, those are the cocktail party foods. You're being fancy, you're drinking wine, cheese, salami, drinking craft beer, you're being all bougie. Can't do that when you're taking linezolid. So I'm going to ask you here, what does that sound like? Do you remember any drugs or drug classes that have those same warnings? In addition to those, we have the risk of reversible thrombocytopenia. And so if someone's taking a course of linezolid that's longer than 14 days, they're going to get their labs checked to make sure they have good platelet counts. And there are some other warnings that you're not having to memorize right now, but I want you to at least have seen that it can have some neuropathies, including motor and sensory as well as optic neuropathies that can impair vision, can cause lactic acidosis, convulsions, and hypoglycemia. So this isn't a super benign drug, but since we're keeping it for MRSA, we're using it when we need to. So the last of the protein synthesis inhibitor classes does not act at the ribosome itself. So this is the only one that doesn't act at the ribosome. And these are isoleucyl tRNA synthesis inhibitors. This is mupirocin or Bactroban. And again, it's not a ribosomal inhibitor. So what it does is here's the tRNA for isoleucine. You have the enzyme isoleucyl tRNA synthetase, and that's going to catalyze the addition of isoleucyl amino acid onto that tRNA so that it can go and become incorporated into that chain. Mupirocin blocks that enzyme and prevents the isoleucyl from being attached to the tRNA so it never gets incorporated into the bacterial peptide chain. If you don't get that incorporated into the chain, then you're just missing all of the isoleucyl amino acids for every protein. So that's going to either terminate protein synthesis or going to make proteins that just don't have the right amino acids in them and aren't functional. So mupirocin is effective against gram-positive staph and strep, and it's really only given topically. And the reason for that is it's broken down very quickly systemically. So if you were to try to give it systemically, it would just be gone immediately. If you're giving it topically, it's going to stick around and have its antibiotic action. So why am I making you guys know which ones are 30S, which ones are 50S, which ones have overlapping binding sites, which ones have unique binding sites, and which ones don't act at the ribosomes at all? And here you're really thinking about, are you blocking other antibiotics from binding? Because if you've got a complex infection, you may need to have 2 different antibiotics at the same time. So infectious disease pharmacists are going to be able to come in, see which type of bacteria it is, see what its particular resistance profile is, and then kind of develop a cocktail of antibiotics for what's really going to kick that infection. If you gave 2 30S, they're going to inhibit each other. You're least concerned about giving a 30S plus a 50S because they're binding to completely different places. When you come down to the 50S's and you start thinking about using 2 50S's together, well, you're going to need to have known that macrolides and lincosamides bound to the same place. So using those together would have limitations. And then, as the pharmacist, you're going to want to know that the oxazolidinone is going to have that specific, unique site that none of the other protein synthesis inhibitors have. So it won't interact with other ones, but is also being reserved because it's not going to have as much resistance. And then you're going to know that the isoleucyl tRNA synthesis inhibitor is completely different from any of the others.